Welcome everyone to Aligning Values, What Matters for Health. We're pleased that you were able to join us this evening. The University of Alberta respectfully acknowledges that we are located on Treaty 6 territory, traditional lands of First Nations and Métis people. A few housekeeping items before we get started. The lecture will be about 40 minutes, followed by about 20 minutes for questions afterwards. For those in attendance, you can line up at one of the stationary mics on the stairway. If you are watching us online, you can type your question into the chat box at the end of the lecture and we'll read out your question for you here. Photographs and video recordings will be made tonight. If you have any concerns, you can talk to me or anybody else with a gold name tag and we'll answer your questions. And when you came in, you were given an event evaluation form. If you could please take the time to fill that out. It helps us for planning our next lecture. And when you leave, you can drop them in the basket just outside the door. If you are sharing about the lecture on social media, please use the hashtag TIPHlecture. It's now my pleasure to introduce Elder Rick Lightning. He is going to say a few words this evening to set the intention for Stephanie Montesanti's presentation. Elder Lightning is a Plains Cree elder from Maskwacis First Nation, and he was raised in the traditional ways of his tribe. He's a third-generation residential school survivor. Elder Lightning is certified in mediation, negotiation, and restorative justice, and he facilitates wellness and cultural workshops. He's also a mental health therapist. Politically, he's been active, serving as a band counselor for his nation. He assisted in the development of the United Nations Declaration on the Rights of Indigenous Peoples, and he served as a cultural advisor to the Truth and Reconciliation Commissioner Wilton J. Littlechild. Currently, Elder Lightning works with the Maskwacis Health Services as a cultural support worker for a number of different programs, and he also serves as elder in residence for the Faculty of Medicine and Dentistry. He said to make sure I included dentistry in that. Elder Lightning, I'll give you some time to share your remarks.
Thank you. That's me here, eh? Okay. Tanse, teutemptik, mapumaskwa sigason, paskamos sa sawa sa sagaan ma notawi, maskuchiwino kanichay sinowak. Hi, my name is White Bear. I come from the Buffalo Child family. I come from the Bear Hills people. And you know, it's really interesting when we talk about health and we talk about what is that happening. Today is an interesting time in our lives. I always tell people every day is a ceremony. The minute your feet touch the floor, your ceremony starts that day. In that day, people are born, people get married, people break up, people die. You might see somebody you really like. But the thing is, in that one day, that ceremony, a lot of things happen. We just don't realize that day. It's your ceremony of life. And the ceremony's over when you finish that day, when your feet lift off the floor and then you go back to sleep. That's the end of your ceremony for that day. So today's ceremony, I'm part of your ceremony today. And I thank you for involving me in your ceremony of your day ceremony today. It's an honor to be part of that. And you know, with everything happening, with the coronavirus happening out there, there's a fear out there of people. But people don't. I was talking to somebody the other day, and I said, you know what? From the scientific point of view, it's a virus. From our point of view as Indians, that virus has a spirit. Everything that's alive has a spirit. And we need to recognize that spirit and figure out how can we get that spirit to stop and cease and desist and leave our people alone. But right now everybody's focusing on the scientific part, but nobody's focusing on the spiritual part, the cultural part. And we need to have that balance between the both. Science and spirituality, because even in our people, we were able to do that balance. We understood spirituality. We understood energy, interdimensional shifts. My people were able to do that. That's what scared the churches of my people, is our energy was based on pure energy from our own selves. And so what the churches were scared of us, because we were able to understand that. Our medicines that we have, these medicines come from 1,000 years. And what happened is, we just didn't go pick this medicine and say, hey, I think this is going to cure cancer. We went to that medicines and we asked them, what energy? We asked them, which one is the one that can help us? And we find that when they let us know, and we would put tobacco down and take that plant and give thanks. Naskamoya. That's how we were able to. Dr. Littlechild gave us a talk about a month ago, and he said, we have the cure for cancer. We've always had it. And, and even all these different medicines we have, our medicine people have them. I spoke at a World Conference in Ottawa, and I said, if you haven't killed all the medicine people in wherever you come from, you're going to have to go back, because the diseases that are coming out are not, science can't keep up with them. But you will have to go to your traditional people and ask them to help you, because you can't keep up. The traditional medicines, whether it's in Australia or South America, wherever they are, there's medicines all over the world and medicine people. But I said, if you haven't killed them off yet, you will have to go back and ask them. And that's so important in the life today, because we're moving into a new age of awareness. These viruses are coming up every 4 years, and pretty soon it'll be every 2 years. And so that's what we need to be aware of, these things that are happening out there. People are starting to, and the reason why we haven't, as my people haven't been so jumping up and saying, hey, we're going to give you the medicine. We did that once, and the pharmaceutical companies took us in the back room and left us there and took our medicines. They cheated us. And so we're not that aggressive, or I don't know what the word is, but we don't want to come out and say this, because we did that once and we got hurt, and our medicines were stolen. But we have those. If people would just do it the right way, the right protocol, they can get help. And it's not an Indian thing, it's a human thing. We're talking about aligning values. The system itself has taken on its own entity. It's dehumanized us. It's no longer human beings. It's just the system itself has taken on its own self. And we need to come back. We need to look at that and look at each other as human beings. And the medicines that are out there for human beings. When they're talking about, what do they say that when you got to go put yourself in quarantine? What's that called? Huh? Isolation. You got to go isolate yourself. That's been going on with my people for a long time. When SARS came, the hospitals in Wetaskiwin and Ponoka told the Indians, you're not allowed to come into town. You got to stay in your reserve. So that's something that's out there. And we talk about values. Where's the values? Where's the Christian values? Whatever values those doctors and people had, the mayor, but they just told the Indians, you guys stay in your reserve. That happened once. And we'll see what happens with this pandemic when it comes down, because now officially it's a pandemic. What's going to happen to the reserves? What's going to happen to my people? And it's something that's important, because in our households, I come from a reserve of 17,000 people. And we have low housing, so 6 per house. So it's going to be interesting what happens there. And so I just wanted to share that with you about what values is. What does that mean? Are we talking values from bureaucracy? Or are we talking values from a human values? Because they're two separate. Sometimes we try to make them the same, but they're not. It's like rationalization is making wrongs right. And that's something we need to be aware of. And each one of us, if there's a time Stephanie has to come to my home, when this comes, and her husband Pat, my Negueme. Negueme means we have the same name. So she's welcome to come into my home. People forget what happened when McMurray had their fire. Where did the people run to? They ran to the reserves, and the people took them in. You didn't see that on the news. The reserves all along took all the fire people in. But did they ever say thank you to those reserves? But that's something. Our people have always been taking people in. Right from Saddle Lake, took the Ukrainians in. When they were left there to freeze to death, our people took them in and helped them to death. Our people took them in and helped them get through the winter. But that's values again. We did that. One thing about our lives, we need to look at each other as human beings. The word settler keeps coming up. I don't believe that you guys are settlers. I believe you guys are partners. We're partners in Canada. You're not going nowhere, and we got no place to go, so we're going to work together. Let's make this country better. But in order to be good partners, you have to have an understanding of us and know who we are, just as we got to know who you are. Reconciliation is not based on, it's not just a word, it's an action. When Stephanie came to my house, that's reconciliation. Eating with my family, having the trust to be with us. That's what reconciliation is about, is taking that effort, making the effort to know one another in order to be good partners. And that's where the trust starts. Not on what somebody else tells you. So many times there's so many people make these, have these assumptions based on their grandfather that thought that Indians were bad people, and you find out that his grandfather told him that. We're not bad people. There's no such thing as good, bad people. We're good people. We've been here for 1,000 years. Longer. I'm a Nehio, and I'm proud of it. My children are proud of it. My grandchildren are proud of it. And my great-grandchildren are proud of it. We have 37 grandchildren. I have 10 great-grandchildren. And I make sure they know who they are and where they come from and what their history is about. So that's something that's important. That little girl or boy? I think it's a boy myself, but okay. That's my grandson. That's our grandson. She's part of our family. She's in our lightning circle. When you come into our circle, it's not just only for the good things. It's for all things. So that's something that's important, and that's life. Is being genuine to one another. And I want to share. I'm going to show you how. I want to share something that's so traditional, because nobody can shake hands anymore. So everybody, when you see each other, follow me. Say hi. Because nobody knows how to do this or what to do. So just go and say hi. Now you all have that traditional knowledge. I'm gonna say a prayer, opening up, and I'll sing a short song. One paragraph, Steph. Hano tawi mo, say what's in. Hanas kumanan minigis kami na. Hawa pate ni chay sino was kami sta pe pipaksita ski mios pe nata makota. Skate mo na wan man pe nata. Which language se utahaya, ut na mawanay tamon sexun. Oxun. Gues se utahaya, gues wapatama, gues betama. Ang gumagwan ma spita gwete kota. Hano tawi ma suwe mo gay sino. When we still kisita hota we still giwetsik. Ikaw mag-iwet na makagwan, mag-skate na moon. Tapon. Ano tayo, mga sewat sinaman askaman, ano tahaya ako ta. Hey ho, hey ho! Yahweh, 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 yo. Yahweh, 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 yo. Yahweh, 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 yo. Yahweh, 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 yo. Hey, hey. Thank you.
Thank you, Elder Lightning, for enlightening us with your wisdom, for reminding us of the importance of the values, of different ways of learning and knowing, and also of the value of true partnership. Our school is very committed to partnerships, and we have Indigenous elders on faculty. We have Elder OJ here with us, and we have students, faculty, community members, and it's a family of partnership that is multi-layered. So welcome one and all to this. This is Public Health Lecture. There are people joining us online, and I want to welcome them as well to this talk. This is Public Health Lecture for us to learn and to think critically about a public health issue. And today we'll be thinking a lot about values. Values are so important from many different perspectives. Growing up in India and migrating to Canada, values were inculcated early in my life. Values of respect, values of learning, continuous learning, and continuous improvement. And so we'll hear that values in the context of health care and health system. And often we find that it is not aligned as we would like. It's misaligned. And what are some of the solutions that we can bring together in partnership? And we're going to hear from Dr. Stephanie Montesanti from her experiences from working with many different communities. So I will not talk a bit more about values. She will provide examples. But let me tell you a little bit about Stephanie. Stephanie is a faculty member at the School of Public Health. She's an assistant professor and a co-founder of Imagine, Citizens Collaborating for Health. She has engaged Albertans province-wide to understand the key elements and values citizens wish to see in primary healthcare delivery. Her areas of inquiry include Indigenous health policy and mental health, collaborating with partners, very many different partners in many communities, from Treaty 6, where we are from here in Edmonton, Treaty 7, and Treaty 8. Examining the health effects of the Alberta wildfires in Indigenous peoples and communities in Wood Buffalo, Northern Alberta. Well-being and mental health among Indigenous youth in Alberta through arts-based intervention to promote mental health and well-being, and strengthening refugee primary care. So as you can see, there's many layered approach to her work. This evening, Dr. Montesanti will challenge us to consider our own values in the public health space, and share with us principles of aligning our values for better health and well-being. And that starts from within, and that starts here. So let me welcome Stephanie to this podium and to share her lecture. Thank you, Shanti.
Thank you, Dean Shanti, for the warm welcome. I also want to thank the School of Public Health for the invitation to give this public lecture tonight. A big thanks to our media and communications team in the school. You worked so hard to organize this event and bring it together, and I thank you for that. I also want to thank Muslim Rick. Thank you for being here. Thank you for being my mentor, and for opening up tonight's lecture in a good way. And to the many people online, there's close to 50 people listening into the lecture online tonight, so that's wonderful. I begin tonight's lecture by sharing the stories of two individuals who were harmed by the healthcare system. The news clipping on your left reads, "Ignored to death. Brian St. Clair's death caused by racism, inquest inadequate." Brian St. Clair was a middle-aged, non-status Anishinaabe resident of Winnipeg. He was a double amputee confined to a wheelchair. In September 2008, Brian wheeled himself into the Health Sciences Center of Winnipeg's major downtown hospital. He had a letter from his physician directing the health science staff to treat his infection and to change his catheter. He was left untreated and unattended to for 34 hours in the emergency room, where he ultimately died from an easily treatable bladder infection that could have been treated with antibiotics, but his condition escalated into acute peritonitis. The news clipping on your right reads, "Patient failed by the system." This is a story of a 31-year-old man named Greg Price from Acme, Alberta, who died unexpectedly on May 19, 2012, 3 days after surgery to remove a cancerous testicle. Greg found himself without a constant physician contact, having seen multiple physicians at the primary care and walk-in clinics, and waiting for referrals to multiple specialists. There was no one person who knew the full picture or was accountable for managing his care. This is the sobering position that we are starting from for this lecture. There are some common elements or characteristics in both Brian's and Greg's experience with the healthcare system. Firstly, their deaths could have been avoided. Secondly, inquiries into their deaths identified multiple system failures. And lastly, they were not treated with care and compassion. But there are also some important differences to understand in their healthcare experience. For instance, Brian St. Clair's death reflects a particular structure of indifference born of and maintained by colonialism. The inquest into his death determined that St. Clair had pre-existing medical problems, perhaps suggesting that his demise was inevitable, and that deficiencies in hospital protocol were at fault. Certainly the latter was a factor, but St. Clair had no alcohol or drugs in his system, and his death stemmed from an easily preventable infection. A family member of St. Clair described that, in quotes, he was ignored to death. However, racism was not considered a role in St. Clair's death, and to divert attention from any talk about racism or colonialism, the presiding judge blamed the system for Brian's death. Greg Price's journey through the healthcare system, on the other hand, and an untimely death, was the focus of a December 2013 Health Quality of Council report. The Health Quality of Council report stated that Greg died prematurely because of multiple gaps in the so-called system of care in Alberta. The 92-page report details multiple breaks in the quality of his care over time, including a lack of coordinated, continuous, and patient-centered care. So what do Brian and Greg's stories tell us about the values of our health system? I'm referring here to the values that determine how we conduct ourselves as a system, how care is delivered, how patient lives are valued, how patients' voices are heard, and how we approach the increasing number of dilemmas our system faces. I'm also not talking about value for money, nor the need to work within fixed funding envelopes or adhere to budgets. These, in my opinion, are not values. They are constraints within which our values must operate. Values are everywhere, like atoms, all pervasive, extremely important, yet sometimes invisible to us. When we look for them, values can be found in many different places, whether in our university setting or institutions, or in our individual or collective values that we believe, prize, and carry forward with us. Policy and decision makers talk a great deal about values. Values talk is found in almost every major health policy document, emphasizing that we need to pay close attention to public or citizen values. But what I've found in reviewing these policy documents is that a definition of values is not provided. These documents focus on thinking with values rather than about values, embedding them in the imagery or the facts that are used to reason on policy decisions. So what are values? The idea of values appeals to us for various reasons that are in themselves values. Values speak to our beliefs that guide or motivate actions and behaviors. Individuals each use their personal values to make decisions, to make sense of the world, and to give meaning to their lives. Values are also shaped by our worldviews. For instance, whether you hold a Western or Indigenous worldview of health. Values are also essential to ethics. Ethics is concerned with human actions and the choice of those actions. And values are what bring people together. Individuals with shared and common values often bind together, sometimes to advocate for a specific cause or to work towards a common goal. Like onions, there are many layers to values. Whatever we consider to be values, whether it's sustainability or health equity, that makes up the outside skin of the onion. What we consider to be fundamental or universal values lie just under this surface. The principles we choose that reflect those values lie somewhere in the middle, and the policy actions they seem to entail lie at the center. So policies, actions, or goals carry with them many layers of values. Unlike chefs, policy decision makers often find themselves starting their work somewhere in the center of the onion, moving right to identifying solutions to various problems, without reflecting on the values that should be guiding those decisions. When we look for values, as I mentioned, we can find them in our institutions, in our scientific facts, as well as what we individually or collectively believe, what we say or do. And when we look for values in different places or among individuals and communities, we observe many expressions of values. However, in locating values, we also observe that health system leaders, patients, the public, and practitioners sometimes disagree over what values are or what values matter most. While all these actors would agree that values should drive policy goals, decision-making, and conduct, they often disagree over what values should take priority. So what happens when our values don't align? Or when we disagree over what values matter? Or whose values get heard? This can result in misalignment between our societal, cultural, and health system values. If we take a moment and reflect back to the news headlines of the two men who died unexpectedly, there were disagreements between the family members and provincial health leaders or other stakeholders within the system on what the causes were surrounding their deaths, demonstrating a disconnect between the values of our society, the values of community or culture, and the values of our Canadian health system. There are also some popular health views on values that many policy scholars have noted, which may contribute to this misalignment of values that I'm speaking to. Firstly, values are not just preferences. We can look at the example of conventional approaches used in health economics versus an Indigenous model of health. So for instance, the most common generic instrument for measuring health-related quality of life is the EQ5D, the Euroqual, which includes a descriptive system that encompasses 5 dimensions of health: mobility, self-care, ability to perform usual activities, pain, discomfort, and anxiety or depression. The EQ5D is a questionnaire that has been used worldwide and is one of the world's most popular measures of health. In order to value an individual's health-related quality of life, the individual's health status is first assessed according to these 5 dimensions. For example, an individual who has no problems with mobility, self-care, or performing usual activities and who has no pain, discomfort, or anxiety and depression would be assessed at a level of 1, which is the most favorable level on all 5 dimensions. Whereas an individual with some mobility problems, but otherwise good health, may be assessed at a level 2 for mobility and a level 1 for all other dimensions. If we look at an Indigenous model of health, on the other hand, applying the same approach to assigning values for health in this context would be considered inappropriate. So if we look at the example on the screen, here this shows a model of supporting healthy Indigenous communities developed by my research colleagues and I. The 7 dimensions for health, for a healthy family system, include healthy supportive grandmothers and grandfathers, healthy knowledgeable parents, kinship, connection to language, culture, supportive environments, and identity. Each dimension in this model are valued the same, and one would not be traded off for the other. This model speaks to Indigenous people's holistic views on health, and thus using a preference-based trade-off or standard gamble approaches may not be acceptable when assessing Indigenous values for health. Values are also not just individuals' deep-rooted beliefs. In other words, society values may differ in form and content from those of its members, and these collective and individual values interact in different ways. Related to this view is the view that individual and collective values do not account for a collective's values. So individual and collective values may influence each other, but neither is entirely comprised of the other. In other words, individual values do not account for their community values, and individuals within a community may not hold their community's values. So when we think about individuals' values, these can include preferences or drives, as opposed to the community or the collective's values, which may include things like cultures, philosophies, or ethics. Weighing values also tells us a little bit about what to do with them. So going back to that first view, that values are more than individual preferences, it is common practice in setting priorities that the public or other stakeholders can weigh and rank individual values by their relative importance. So how do we then accommodate those priority values over others, should values conflict? We need to think beyond how we prioritize values in terms of what's number one, but rather what's on and what's not on the table for discussion and negotiation. So aligning values for health can be complex because of power relations, varying stakeholder perspectives, and the many factors that often compete for government's attention on an issue. But there are opportunities and instruments available to us to help align our societal, cultural, and health system values. I present here my 5 principles for aligning values for health, which I will come back to towards the end of my presentation, but wanted to briefly touch on them here. The first principle is to create spaces for dialogue. The second principle is to confront the paradoxes in values rhetoric or values talk. The third principle is to read between the lines of value statements and policy reports and commitments. The fourth is to zoom out to see the big picture on the factors that shape health. As an aside, I've been referring to the health system in my lecture to acknowledge the role played by social and cultural and community sectors on promoting population health and wellness. And lastly, the fifth principle for aligning values for health is to move through the many layers of values. So think about the onion. Rather than being reactive in finding solutions to addressing health system challenges, we need to move through a process of understanding and defining values of diverse stakeholders and those principles that underline those values before moving right to the solution. While aligning values for health is complex, it is also a necessary challenge our leaders need to undertake. So how do we get there? I will now share on 2 primary healthcare transformation projects in Alberta that were co-led with patient partners, communities, and health practitioners. And I will then describe my journey through these 5 principles for aligning values for health. So the 2 primary healthcare transformation projects include Eliciting values of Albertans on achieving continuous, coordinated, and patient-centered care. And the second project is on building on Indigenous values for transforming Indigenous primary health care in Alberta. But first, let's define what is meant by primary health care. So primary health care is about caring for people rather than simply treating specific diseases or conditions. This includes 3 main areas of focus. 1, empowered people and communities. In other words, individuals and communities should have a voice in decisions regarding their own health. The second area is focused on multi-sectorial partnerships and action. And lastly, the third is integration of health, social, and mental health services, both within a single health facility and across the sectors, which is important for providing wraparound care, continuous care, and holistic care for patients and their families. Over the past 50 years, the way we describe optimal approaches to delivering primary health care that meets the patient's needs has evolved. Today, we are looking at patients' connections to the coordinated services and supports available to them, both medical and non-medical. Non-medical referring to the social determinants of health that enhance overall patient health. Much of this discourse has been included in recent descriptions around this concept of a health home. While a house is a place of residence or refuge, the term home is often used in a more personal and emotional way. It can be an environment characterized by security, safety, and happiness. Key to the health home model is this concept of continuity of care, which is a widely accepted core principle of primary health care. Its benefits are thought to include better physician-patient relationships, fewer hospital admissions as a result, and higher patient satisfaction. So unpacking this concept of continuity of care includes different types of continuities. Informational continuity means that information on the patient or regarding previous or past health events of that patient is used to give care going forward throughout their journey that is appropriate to their current circumstance. Interpersonal or relational continuity, which is an area that I work a lot in, recognizes the importance of knowledge of the patient as a person and an ongoing relationship between patients and providers that connects their care over time. Management continuity ensures that care received from different providers is connected in a coherent way. And longitudinal continuity looks at the care that is provided for patients across their entire course of treatment or illness. And there's been much research that has linked or suggested longitudinal care, so care where a patient is seen by the same practitioner over a long period of time, may also be linked to a high degree of patient satisfaction. In a recent rapid evidence review that my research team has completed for the Alberta Health Services Primary Healthcare Integration Network, we found that personalized discharge planning, as an example, included many mechanisms for following patients after discharge from a hospital or a specialized care facility, and was linked to prevent patients from falling through the cracks. If the health home is designed around the patient and their families, it's important to think about what's important or key for delivering patient or individualized care. Going back to the imagery of the onion, there are multiple layers of patient-centered care. So using that as an example, if our value is patient-centered individualized care, the fundamental values underneath that the outer skin of the onion would be patients and families as partners with healthcare providers to design and deliver individualized care. The principles underlining that value would include respect, dignity, compassion, and equity. And at the core, the policy action or solution would be to improve healthcare efficiencies and possibly address patient safety or harm. Greg Price's story highlighted multiple breaks in the quality of his care over time, including a lack of coordinated continuous care. Building on Alberta's commitment to improve continuity of care for patients and individuals within the health system, we carried out a primary health care project with Alberta Health to explore the values and ideas of Albertans for improving primary health care. That included one-on-one semi-structured interviews, 3 webinars and teleconferences with Albertans to provide a high-level overview on primary health care in Alberta, and an introduction to core concepts such as the health home or continuity of care. And lastly, a face-to-face citizen dialogue. The aim of the citizen dialogue was to learn about Albertans' values for primary health care and to develop ideas and policy options for what a health home could look like to improve the health and well-being of patients or Albertans. So who did we engage? 31 diverse Albertans from across the province were engaged in the citizen dialogue to learn about their experience with the primary healthcare system. Participants ranged from the age of 18 to 75 or older, and from a range of different settings or cities, including 11 rural representatives from northern, central, and southern regions, 20 representatives from cities including Lethbridge, Calgary, and Grand Prairie, Fort McMurray, Red Deer, and Edmonton. So what did Albertans say about their primary healthcare system? Or what values should drive primary healthcare transformation in the province? I show here just a few quotes that emerged out of the dialogue. So the quote on the left reads, "Having a consistent relationship means that a provider knows your history, which reduces the number of times that you have to tell your story or undergo duplicate tests. When focusing on solutions, there is emphasis around the role that a patient navigator or community health worker can play in the clinic to support patient navigation and coordination of care." And the last quote here, which refers more to informational continuity, was talk around access to our own patient records. So as this Albertan said, "Why can't I see my patient records? They are my records, they are about me." What came out of that citizen dialogue was a new concept or version of a health home that reflected the values, perspectives, and experiences of Albertans that we engaged. At the foundation of this health home is patients as partners in the healthcare system. And the key elements relating to continuity of care include information access and sharing, ease of navigation, so how patients are able to navigate throughout the healthcare system or from one setting to another, and the relationships and trust that they built with their physician or healthcare provider. A modern industrial healthcare system can be a determinant of ill health, especially where it is culturally unsafe. In the Truth and Reconciliation, calls 18 through 24 address the role that healthcare has played in colonialism and calls on federal and provincial governments to make serious and far-reaching changes to acknowledge that the current state of Aboriginal health in Canada is a direct result of previous Canadian government policies. I think we need to be candid, or else we miss the point of what the TRC asks us to do. We need to transform through listening, hearing the truth, and achieving a state of reconciliation. I see the TRC as an instrument that can be used to help us align our values for health. Between the years 2016 to 2019, our team organized a series of policy dialogues to explore innovative models in Indigenous primary health care across Canada. We also facilitated roundtable discussions to generate consensus and prioritize directions for Indigenous primary health care delivery. And we convened province-wide engagement with health system leaders and Indigenous communities. What emerged from those engagements was a vision, a collective vision for renewed Indigenous primary health care in Alberta. This vision is to promote a primary health care system that achieves Indigenous health equity by advancing research that links knowledge to policy and practice based in equity and Indigenous ways of knowing. We also worked with Indigenous health service providers, community members, and other stakeholders to identify key directions for Indigenous primary health care. These included community-based research, which serves as a vehicle for change and transformation, to promote cultural competence among primary health care professionals. So how do we build self-awareness and understanding within the healthcare profession? The achievement of health for Indigenous populations that requires us to acknowledge and address the social determinants of health, so proximal, intermediate, and distal determinants of Indigenous people's health. And through the engagement with Indigenous patients, and by engaging Indigenous ways of knowing, worldviews, and values, that those need to be incorporated into current systems of primary healthcare delivery and transformation. And the last direction refers to measurement. So how are we measuring and assessing values? And that those measurements should be derived from those involved in their healthcare. Innovations and measurements can validate and align Indigenous knowledge with the primary healthcare system. The damaging and uneven historical relationships between Indigenous people and non-Indigenous Canadians means that many Indigenous patients have apprehensions about the Western medical system, which for many remains a living symbol of continuing oppression, mistreatment, and neglect. This framework here builds on work of my colleague, Dr. Lindsay Croshoe, which focuses on recentering the clinical relationship that involves attending to colonization and inequity within the healthcare system. The framework directs clinicians to address dynamics related to unequal treatment and the imbalance of power and authority. So clinicians must become aware of their potential complicity in perpetuating these concepts. Critical self-reflection is an important first step in identifying one's own biases, stereotypes, assumptions. And the framework also suggests what the concepts of cultural competency, cultural safety might look like for Indigenous patients. Culture here is viewed as a protective factor and a facilitator for improving health. This should not imply that all patients are equally connected to traditional Indigenous practices, but that culture serves as a role in positioning a person within wider networks of community and support. The framework also highlights the importance of shifting our mindsets. Mental models refers to our habits of thought, deeply held beliefs and assumptions that are often taken for granted, that influence how we think, what we do, and how one talks about a problem. And sometimes our mental models can hold the problem in place while preventing us from finding meaningful solutions. And the framework also acknowledges or highlights the importance of the social realities of Indigenous peoples. So how do we engage those social realities to shape or inform our self-awareness and understanding of the Indigenous client or patient's experience? And now I return back to the 5 principles for aligning values for health. The first principle, to create spaces for dialogue. A process of dialogue supports a shared vision of health, a reality that is equitable and reflexive. We need to acknowledge or incorporate different ways of knowing in decision making. And I show here an example of how these two different worldviews can come together in this ethical and safe space. That ethical and safe space is a space that no one owns, but is based on mutual respect and understanding. And we can look here at the example between Indigenous knowledge and Western knowledge. Confronting the paradoxes. The key paradox is that our discourse about values is both very important and very ambiguous. We often debate values without reducing them to what they mean for instrumental ends. Therefore, we need to explore the disjunctures between the values people champion, follow, and act upon. As this quote here from Ryan states, values gives us the questions to ask. Without values, we would have no questions. While some problems are so obvious to us that we need not reflect upon them, most social problems do not come to us readily defined. We can approach the same problem in different ways, and different people could hold different interpretations of a problem at the same time. We also need to read between the lines to critically assess how values are framed and the language that is used to express those values. Declared values can be guiding or misleading. In our engagement with Albertans and stakeholders working in Indigenous primary healthcare, we observed multiple expressions of values. If we don't define or seek clarity on the motivations or principles that are driving those values, it can steer us in the wrong direction. The fourth principle, to zoom out, to see the big picture. We see healthcare happen most clearly in the interaction of a medical profession and a patient. This is how we most directly experience healthcare. Of course, we know that this is an incomplete picture. Doctors don't just appear out of nowhere, ready to heal, and patients don't magically find themselves in hospitals. To see how we got to this interaction, we need to zoom out from healthcare. The healthcare system is only one element of a much larger system that influences the health of an individual. Our health outcomes can be shaped by other elements, as identified here on this slide, which can include water and sanitation, environmental conditions, food security, safety, and safety. This is a model that I've created to illustrate what individualized care looks like as we zoom out from the health system and our service delivery system to identify the many contextual factors or variables that influence patients' health. So this model on the slide highlights the institutions or structural constraints that may underlie patients' ability to negotiate and move through the complex maze of the health system. Lived experience also encompasses how we understand the world and our relationship to it through our positionalities, affected through our identifications with gender, ethnicity, race, nationality, religion, age, and so on. And lastly, we need to move through the many layers of values. As we go through the layers of values, we move from descriptive reasoning, that is, what values are important, as well as instrumental reasoning, that is, what should be done with values and how. So, can we align values for health? I believe that there are opportunities available to align that exist through meaningful dialogue and relationships. We need to, as Muslim Rick had said in his opening talk, that we need to move outside this gray area that we call rationalization and begin to ask some tough questions. I mentioned that the TRC can be an instrument, the Truth and Reconciliation Commission can be an instrument for helping us align our values. The realities I've described in my lecture tonight continue to prevail, such as the high number of people admitted into hospital who experience harm that is avoidable. Our current climate of healing demands an organized and respectful health system response for Indigenous populations. Such a system response needs to be based on values, ethics, and trust, and be strategically aligned to inform good governance and policy. Where there might not be opportunities for aligning our values is where we continue to see power dynamics and underlying mental models that impede that alignment between societal, cultural, and health system values. So I'll leave tonight's lecture asking you what's important to you. Thank you. Sorry, and I just wanted to acknowledge and give thanks to my research colleagues, my partners at Imagine Citizens Collaborating for Health, and of course my community and patient partners, Rick Lightning, and the work that I've been more recently involved in with Patients for Patient Safety Canada. Thank you.
That's great. Thank you, Stephanie. Let's give her one more round of applause for that. I'm going to open up the discussion here for any questions that people may have for Stephanie, either online or in person here. Do we have any questions? If you could just come up to the mic over here, if there's anybody, or that one. We have two. Lisa's giving me signals and directions as I talk here. Any comments? Any questions? Online there, Donna, do we have? Okay.
No questions?
For students, values become important, right? In the
Right.
context of what we talk about and really understanding public health and the underlying rationale for why we get together and talk about these things in open dialogue and discussion.
Hello.
Colin.
Hello. First of all, thank you very much for your talk today. Kind of a quick question about moving forward with aligning values, and particularly the ones you talked about for the health system, kind of within the current constraints within the province as you outline them, that they're not necessarily aligning values to values, but perhaps the values within those constraints. If you could talk to that a little bit, that would be great. Thank you.
Yeah, sure. I'm assuming you're referring to COVID-19? Or just fiscal realities. Oh, yes. So, yeah, there's been much attention lately focused on primary health care in the news. The latest has been around the values of primary care family physicians and Alberta government's decision to change the funding model. Right? So certainly that is a really good example of highlighting the role that values play. The position family physicians have been taking is that it would drastically change their ability to provide good quality care to patients. It's hard to say where the direction we're heading into in terms of the fiscal realities and the funding constraints, but it's something that our public and Albertans or citizens are genuinely concerned about. And if we don't meaningfully engage and involve Albertans into that conversation, then we might be steering in the wrong direction in terms of making decisions that can create further harm than good. Right? So during these tough times, whether it's public health emergency or fiscal constraints, we need to be engaging all stakeholders that are implicated by these issues. Yeah. So how do we align those values, create those spaces for dialogue, have conversations? There's been little evidence so far in terms of having province-wide consultations or conversations around this, right? And it's certainly creating a lot of panic and fear among our population.
Stephanie, I have a question for you from the online audience. Do you have any suggestions on how to improve cultural competence among healthcare providers?
Yes, so that framework that I showed speaks to that. So the short answer to that is self-awareness, acknowledging your own biases, assumptions, or mental models or mindsets about how we provide care. We need to recenter that relationship, between the patient and the provider, right? Acknowledging the patient's realities and histories, right, is really important. And that's really the hardest thing to change. And while this framework provides us a tool to get there, I'm not saying that it's easy. When we look at the factors that influence or shape healthcare transformation or change, we can add, change the resources, we can change how we fund things, we could, there are a number of different factors and components that can be brought into how we transform or change a system. But the one that's the hardest is shifting our mindsets or mental models. For getting people to let go of their own tacit infrastructures or biases, to understand or to zoom out and see the whole picture and to understand the realities of and lived experiences of diverse patients.
Yeah, hi, Brian Rowe. I'm a
Hey, Brian.
professor in emergency medicine and emergency physician at the University Hospital. Thanks very much, Stephanie. Really appreciate your thoughts on this. I have about 1,200 questions, but maybe just limited to two. What bias do you see associated with your selection of patients to interview? Our experience is that some patients, particularly the social media savvy young people, don't really want a family doctor. They're facile in getting information that they think is valid. They're not smokers. They're wearing their helmets when they're biking. They're exercising. They're choosing a lifestyle that's perhaps not necessarily requiring physician input or a healthcare team input. So they don't choose to go to a family doctor. And you may have missed them. You may have had people who really believe in primary health care. So I wonder if you can speak a little bit about that.
Yeah, I can go back to the example of the citizen dialogues that we held with Albertans. And that one actually really speaks to some of the points you're mentioning. So when we discuss different concepts around attachment, and some of us in the room will know what attachment to a primary care physician means, and it just means in terms of continuity of care that you're attached to that family physician and you have that ongoing relationship with them throughout your care journey. Attachment was considered to be a negative or sometimes dirty word for some patients, where they felt that it was a forced relationship or forced interaction that they had to have with a provider and didn't give them the freedom to choose, right? So when we really unpacked a lot of these concepts that we often see in these policy reports or commitments from our provincial leaders, they had different meanings and expressions that they would attach to those different care experiences or concepts. So for them, it was more around changing the language, changing how we're talking about it, or changing the discourse around it. So rather than thinking about it as an attachment to a primary care provider, let's think about it how we can actually support meaningful, trusting relationships with our care provider, right? They valued the idea that having a provider that can follow them through the care journey was something that was important for them. So there's certainly a disconnect with respect to values discourse or talk and how we may tend to frame certain commitments or decisions or policy options that may not be inclusive or reflective of how they're thinking about their care experience. Does that answer your question, Brian?
A little bit. We can probably talk after. And my second question is that, when we see patients in the emergency department, 30% of those patients have no family doctor. And even if they had a family doctor, they couldn't get to a family doctor. If you look at the Commonwealth survey, we have some of the worst performances in the primary healthcare field in all of the developed countries. So, I think it would be great if people had that relationship, but they can't even get in to see their family doctor. So, or their family healthcare team, whatever you want to call it. And so I actually think that the system is so broken that those relationships are going to be very difficult to achieve unless we get people in to see providers and the team when they need it. And that will require drastic changes in the way we support training in family medicine, more residents, less walk-in clinic focus, and I think it's going to take a change in the funding model. Can you talk about that a little bit?
I agree. completely, Brian. And I think that was the impetus around carrying out that citizen dialogue, right? Is sort of putting the cart before the horse scenario, where we were, the Alberta government immediately jumping to a solution, right? How do we address the fact that patients are falling through the cracks, right? The reality that patients are experiencing challenges in accessing or getting into a primary care clinic. So the things you noted were realities that provincial health system leaders were aware of, right? So while we're often quick, our leaders are quick to jump to the solution to that core of the onion, we had to take a step back and think about, well, what do patients actually say about this? What are Albertans saying about it? And we need to really unpack that a little bit further to better understand what those challenges were that they were experiencing, right? And we saw that play out in different settings, whether they're patients in rural and remote communities or in major urban centers. So in terms of how do we address some of those system challenges, certainly engaging or creating those spaces of dialogue helps us to better understand the problem, rather than just putting the cart before the horse and moving directly to a solution because we want a quick fix or to find a quick remedy to address the problem, because we know the problem sometimes comes with unsettling realities, whether it's costs, high costs in the healthcare system, readmission rates in the hospital, et cetera, right? And those are realities that often don't sit well with our provincial health leaders, right? So while we're so quick and focused on those solutions, we need to take a step back to think about, well, if we're going to identify the solutions, we need to ensure that they are the right ones. And how do we know that they're the right ones, right? And so having that meaningful dialogue and engagement of all stakeholders, not just citizens or patients, but healthcare practitioners and leaders as well, ensuring that those multiple worldviews and perspectives are acknowledged.
Great. Elder Ogier, I see the hand there. Would you mind going to the mic, and this will be our last question or comment for the night, so we give you the final word.
It's a little bit low. Can you hear me? I just wanted to make a comment on relationships with Indigenous people and providing relationships and what that means. So for me, my journey has been almost 60 years ago, or a little over 60 years ago. I was born in a bush, and I'm so proud to tell you that. I was born in the middle of nowhere and raised in a very traditional lifestyle. And to me, what does building relationships mean? Because I wound up in Graham McEwen College. I wound up living here in Edmonton. I wound up 25 years as a social worker with the Alberta government. All being fluent in the Cree language and the Cree culture and in and out of our communities on a regular basis. And I often thought that if we can bring you the story, and someone asked, so what does building relationships mean? What does building a partnership? How do you go about doing it? I'm more of a practical guy around that. Right? I'm a practical teacher and a practical learner. And so when things like the blanket exercise and intro to Indigenous training came along, I jumped at the opportunity for me to tell the story. So what does that mean? So if you ask me what whitefish means, again, we're still in the middle of nowhere, right? We're still in a bush, we still hunt and fish, and we still do the Cree language, and we still do Cree traditions. So when I come to a university, to me, it's a whole different world. At first, it felt like I was on the moon, right? So I ran into people like Stephanie, like Elder Rick Lightning, and all these different people told me, you will do well here to come and tell our story. I was just so scared, So 25 years in government helped alleviate that, of course. So I get a lot of questions then. Where is Whitefish? Who are you guys? Is there a health center there? And who's your doctors? Where do you get your health care from? We go to High Prairie or Slave Lake. So it's a whole different, so we have family doctors, yes, but we also have a lot of, I'll be quite blunt in some of my comments, that a lot of our people are quite poor, right? Financially poor, but they're rich in culture. So that helps them when we pray and when we talk in Cree and we start getting proud of who we are. Cree people, Woodland Cree people that have been here at least 15,000 years. according to the U of A geologist I talked to, and anthropologist not too long ago. 500 generations, so that's a lot of history. And so I go to wilderness camp at Elk Island on a regular basis, and we tell them about diamond willow and red willow, how they're painkillers, and how we've used them for thousands of years, how we do that. So when the doctor said, here's an aspirin, it'll help with your headache. So, and then here's the diamond willow, it'll help with your headache. You see how what a diverse world that is? And what diverse people we are. Like even the Woodland Cree, the Plains Cree, the Dene, the Bloods. So to me, for the health system to know all that would be good. If they knew who we are and how diverse we are, that would be a good thing. And we want to tell you. We want to teach you that. That's the practical answer. We want to talk to you about it. I was talking to a friend of mine, Dennis Whitford, and he says, Bert, you gotta go to Germany. I said, why? Why? He said, because when you go to Germany, they'll treat you like a rock star. I said, how come? How come? He said, they have the Turtle Island, the North American people in their curriculum, the North American Indigenous people in their curriculum. And they do powwows and all kinds of stuff there. I thought, oh my God, that's wonderful. I think I'll go there. But the simple answer, the simple line to that story is this. We should have that in our curriculum. The Cree people in Alberta, the Bloods, the Dene, the Nakota Sioux should be in our curriculum. We should automatically know that there's 52 First Nations in Alberta, 8 Métis settlements, 4 different kinds of governance systems, because that all leads to healthcare, right? That all leads to the holistic approach that we take to healthcare. If you want to know, ask us. We're ready to talk. We're not scared anymore. We're not scared of RCMP, doctors, or lawyers, because we have gotten educated, right? And at U of A, we have over 1,500 students as we speak. So we're so proud of that, and we're so proud, and we want to share that with you. So if you want a practical answer, come and ask.